Good evening, good afternoon, everyone. This is Adavshin on behalf of IGCP. I warmly welcome to all our respected doctors and participants for today's digital live session. Today's topic is pediatric sepsis, spotting the early signs that save lives. Focuses on one of the most critical emergencies in pediatric practice. Sepsis in children often represents with subtle, non-specific signs and delayed recognition can rapidly lead to life-threatening outcomes. Early identification, prompt intervention, and standardized protocols are key to saving young lives. This session aims to enhance and clinical vigilance and provide practical insights into early detection and management of pediatric sepsis. It is my privilege to introduce our speaker for this afternoon. Professor Dr. Sunil Kumar Agarwala sir. He did MBBS, MD. He is professor in Department of Pediatrics, Sardar Vallabhai Patel Postgraduate Institute of Pediatrics in Cuttack. Professor Dr. Agarwala sir is a highly respected pediatrician and academician with vast experience in pediatric critical care and infectious diseases. His clinical expertise and teaching excellence make him the ideal speaker for today's life saving topic. With great pleasure, I now hand over the session to Dr. Professor Sunil Kumar Agarwala sir to take us through this crucial and informative discussion. So, this is over to you. You can proceed with the next, sir. Thank you.
Thank you very much, Upsin, for your nice introduction. Good afternoon, dear doctors. I welcome to this webinar organized by IJCP platform. I must thank all the members who are helping in this type of communication in medical knowledge across the country. I thank all of them. So, dear doctors, as we know, among the pediatric sepsis, the sepsis word is more used left and right in neonatal age group. Why? Because neonates are more vulnerable for any infection. Why? They are the more the prematurity, more the chance of infection, more the what you say exposure, there is chance of infection because the immunity is immature. We can say because of non-maturation of the immunity, both T cell and B cell, they are more vulnerable for neonatal sepsis. So going further, we'll be discussing in different domains, epidemiology, what do you mean by define, what are the risk factors, etiology, organism profile, what are the organism, how to diagnose and treatment. Now coming to epidemiology of the neonatal sepsis, why it is important? Because already I told India, the number one neonatal death in the world, not only in India. So this is most likely neonatal sepsis. 8% of deaths due to sepsis within first week of life. That means if we can prevent this death, then definitely the neonatal mortality as well as infant mortality will go down. Leading cause of neonatal death after 7 days is also neonatal sepsis. Now, if you see early period, that is 0 to 6 stage, intrapartum, preterm, sepsis. So sepsis is contributing towards 8% of early neonatal period, that is 0 to 7 days, and late neonatal period, I mean late, that means 7 day after 28 days till the sepsis is more taking lives to the tune of 37%. So among them, so many infections are there, intrapartum and postpartum. So the 10 countries with highest neonatal death, India is the number one, and thereafter lot of countries they contribute. But where is the population high? So we can say the preterm delivery in India is the highest amongst the globe. The population is highest, so definitely we are dealing with sepsis number in children is also highest, and the number of delivery that do occur in India is 27 million birth cohort, and 30 million, I can say, the pregnancy do occur in India per annum. So definitely we are getting a major chunk of neonates, they are vulnerable for neonatal sepsis. So in this way, the definition already as the time bound less than 72 hours if the baby is suffering from any kind of sepsis or clinical presentation or investigation or lethargy, that is known as early onset, and the late onset is beyond 72 hours. Why this 3 days 72 hours cutoff? Because this early onset is is related to the birth passage microflora, but the late onset is always the organism is received from the environment, that is community acquired. So this sepsis, presence of signs and symptoms, and isolation of bacteria from the sterile body fluid or site is known as sepsis. Clinical sepsis, yes, positive signs and symptoms, but negative lab culture and lab results, that is clinically sepsis. Probable sepsis, positive lab results, but negative culture along with symptoms consistent with sepsis. So many a times, if a baby is received by us and there is some lethargy, something, and lab results are also negative, that is probable sepsis. So in that condition, we are not giving full course of antibiotic. But having said that, in clinical sepsis, definitely the culture is negative, so we are giving amicable duration of antibiotic for the duration of 7 to 10 days. But in a prevent sepsis, the duration is 7 to 14 days. But in that condition, because the culture is positive from the body fluid, from the blood, so definitely the duration of antibiotic will be little more. So going further, what are the pathogen? The pathogen profile is gram negative. We always remember lesser the age, less than 2 months, the gram negative sepsis is more common than the gram positive sepsis. So out of positive organisms, Staph aureus and coagulase negative Staphylococcus, both the organism is Staph aureus. So that means gram positive sepsis to the tune of 37%. 63%, or you can say two-thirds of the sepsis is caused by gram-negative pathogen, Klebsiella 23%, Acinetobacter 8%, and E. coli 47%. So out of the list, the most common organism causing neonatal sepsis, let it be early or late, the Klebsiella remains as the common bug. Then comes your Staph aureus, that is more common in, again, this late onset sepsis, Acinetobacter, E. coli, and these organisms are particularly gram-negative organisms. So, in nutshell, the gram-negative sepsis is more common than gram-positive sepsis in neonates in comparison with older children. So, microbiology profile, if you see retrospective data analyzed in 2019, 18-month data, then there are other literature, they say that if you see that gram-positive organisms starting from coagulase negative staph, then Staph aureus, then comes Enterococcus piscium, Enterococcus faecalis, fungi. Sometimes fungal sepsis can occur in a long duration of stay inside the NICU and PICU that can lead to fungal sepsis. Among the fungi, the Candida and you see Wicker monocytosis species, they are common, but gram-negative bacilli, Klebsiella number one, already I told, Acinetobacter baumannii is the second, then Burkholderia species, then Pseudomonas E. coli and Enterobacter. So if you analyze all those things, most common organism causing sepsis is Klebsiella, and most common gram-positive organism causing sepsis is Staph aureus, and another is coagulase negative. And coagulase negative being the skin pathogen, so this is outnumber the number of coagulase positive Staph aureus. So what are the risk factors of early onset? It is impaired immunity, it is a immaturation of immunity, immature skin barrier. So all those things, if you see the amoeba, fungi, and all those things. So if you see independent of other cells, then native innate immunity is also low, leukocyte-based innate immunity, all those things. In one line, the immaturity of the immune system allows this pathogen to enter into the body surface because of intactness of barrier may be fragile, and there may be a breach in the epithelium and mucosa. The organism, they get a pathway to enter into that. So that means in cases of fetal, newborn, infant, and adult, if you see this barrier is more well established in the older children, but the barrier in the mucosa, particularly in GI and skin, they are very vulnerable for the entry of the pathogen, and that causes more vulnerability of the earlier neonates into the sepsis. So, coming in continuation of risk factors of early neonatal sepsis, incidence of chorioamnitis in preterm. So, if the maternal fever, if the maternal UTI or maternal chorioamnitis or foul smelling liquor, they are, you can say, predisposing factor for the onset of early onset of neonatal sepsis. Or if you say there are multiple factors are there, that resuscitation at birth, need for artificial ventilation, that is bag and back or bag and tube ventilation, less the maturity, I mean more prematurity, mode of delivery, that is vaginal delivery, all those they play a major role in anticipation of early onset of sepsis in newborn. So coming some slides on late onset sepsis, most common cause is hands of healthcare workers and family members, contaminated equipment. So that's why we love to tell that means the segregation of the mother and baby at least for 1 month in the family is very important, and that's why there is some notion in some part of India that you go to Gujarat, you go to Maharashtra, that they are rooming in and lying in particular one corner of the house. They are not, nobody is allowed to touch the mother even, not the baby even, and that separation plays a vital role in rooming in, liming in, and kangaroo mother care. All those things, they have a close proximity of the body flora with the microflora of the newborn. So more colonization of the gut by a good flora, and that prevents the onset of sepsis. So meningitis mostly hematogenous but can occur from contiguous spread of result of contamination of open neural tube defects and congenital sinus tracts. So if there is a open or perforated or that burst out neural tube defect, if that is there, then definitely we can say that this type of entry of the pathogen can lead to late onset sepsis. Hypoxia, acidosis, hypothermia, inherited metabolic disorder like galactosemia, they always allow the child vulnerable for late onset sepsis. As already we developed, we say that if there is early onset of sepsis, the birth flora, they are the culprit. But if it is a late onset sepsis and the sepsis develop after 72 hours, then a lot of factors, particularly community acquired organism, are the play in that condition. Contaminated equipment, more handling, and more handling. And sometimes you see in India that 21st day ceremony, and particularly they used to go for a lot of persons going to the house and handling the baby will allow this late onset sepsis. Breast milk. So inside this time, that early neonatal period and late neonatal period, exclusive breastfeeding and early initiation breastfeeding and rooming in, lying in, and breast crawl. All these are vital component to prevent the sepsis, because breast milk is rich in a lot of antibodies, and thereafter it is known as the live secretion from the breast, that is equivalent to the mother has power to secrete white blood from the red blood, that is milk, and which is rich in this wealth of I mean powerful leukocytes and antibodies, and you say all these factors, that means lysozymes, all these factors, they do not allow the child for the sepsis. So that's why a term baby breastfed exclusively, then definitely they are less chance of neonatal sepsis. So neonatal sepsis symptomatology, temperature instability. Many a time the thermoregulatory center is not mature enough in newborn. So usually they present with hypothermia. So if the trunk is warm, the extremities are not warm. That is cold stress. That is the most first early presentation, and thereafter the child will develop complete hypothermia, and hypothermia can lead to hypoglycemia, and the cascade of event will follow thereafter. Neonatal sepsis symptomatology, respiratory and severe symptoms can be non-specific, superimposed on RDS and BPD, sometimes difficult to interpret the chest X-ray. The chest X-ray may not show shadow, but if you see the child is lethargy, there is tachypnea, but the chest X-ray is normal. So in those conditions, you have to see the mottling, that the skin mottling, the CRT is prolonged more than 2 seconds. All those things will guide us that you are dealing with a advanced sepsis. Now, particularly if you see the pustules over the body, if they are less than 5 or less than 10, that means in number, they can be treated with local topical ointment. But if it is a big, and you see these are bigger pustular lesions, so they are not neonatal pustular melanosis, they are infective etiology and it has to be treated. If it is a big one, more than 1 centimeter, or the number is more than 10, then definitely it has to be treated as a systemic sepsis by admission. If you see this type of gangrene, either the pseudomonas, or sometimes this type of gangrene can occur due to meningococcal sepsis even in a newborn. So skin and soft tissue infection, this ecthyma gangrenosum is more common in definitely they are more vulnerable for pseudomonas infection. Staphylococcal pustulosis, I have already shown. Sometimes herpetic lesions, they also can present with vesicles on the all over the body, and sometimes they can present with herpes labialis and herpes zoster like presentation. So meningitis, all sepsis, they do not land with meningitis. But if you see infants at risk for early onset sepsis, incidence of meningitis is 1 to 2%. But whereas 2019 American Academy of Pediatrics on CSF is suspected early onset sepsis, any infant with culture positive bacteremia or infants with clinical course of lab data suggestive of sepsis or infants do not show any clinical improvement despite the antibiotics. These are the conditions where meningitis, underlying meningitis has to be suspected. Incidence of meningitis is high in late onset sepsis to the tune of 10 to 23%. It can go up to one fourth of the total number of late onset sepsis. So incidence is inversely proportional to gestational age. Less the gestational age, more chance of sepsis, more chance of meningitis, directly proportional to postnatal age. Up to 30% babies with meningitis have negative blood culture and CSF to be done in all cases of late onset neonatal sepsis. The message is that any neonatal sepsis which is late onset, the CSF study has to be done to rule out, because in neonatal sepsis we are giving the antibiotic duration for 1 to 2 weeks. But however, in cases of neonatal meningitis, the duration will be not less than 3 weeks. So diagnosis, there are many this acute phase reactants are there. So discussing the CRP, which is available now in the community level as well. Now PSC new everywhere on India, this CRP is available. CRP elevated or not elevated has no meaning. The rising titer of CRP has a value. So negative CRP sometimes rules out the possibility of sepsis. There are many sepsis mimicker are there, that is dog dependent lesions, or you can say IEM. They present like sepsis, but the negative CRP has a very good probability rather than positive CRP. Positive CRP can occur due to inflammatory conditions like HI babies, even cases where if you see there is a TTNB and Malthus fixa baby, they can have CRP as well. First found in patients suffering from that pneumococcal disease, formed by hepatocytes after induction of IL-6 and IL-1 beta. So IL-6 usually induces the production of CRP from the hepatocytes in the liver. Cut-off value is 10 milligram per liter. So infant born with vaginal delivery, difficult extraction can have CRP higher. I have already told that any stress can lead to CRP elevation. Starts rising 4 to 6 hours after stimulation, peaks around 36 to 48 hours. So usually on day one onwards, that means 24 to 48 hours onwards, you can get rising titer of CRP, and half-life is 19 hours, sensitivity and specificity is 62%, 74%. So negative predictive value is more than the positive predictive value. Performs better in low light, means late onset sepsis. Adequate time for IL-6 to induce CRP production is around 24 hours onwards. Now this CRP is elevated and very low sensitivity. I have already told, good specificity and negative predictive value is more, and this is available pan India at any I can say primary level. Its value is available. So always remember the lab data or lab value that differs from lab to lab. Many where it is available as more than 6 is as a cutoff, and sometimes more than 1 is a cutoff, more than 10 is a cutoff. So go to the local standardized value, whatever is available. Go with that for the interpretation of CRP. Now, next few lines on Procal. This procalcitonin is an hospitalized setup, particularly in medical college and subdivisional and divisional hospital or government district headquarter hospital. This facility may be possible. In our medical college, it is available and it comes faster than the CRP comes. So that means it is a pro-hormone of calcitonin without hormonal activity. So it is a pro-hormone, and mRNA is synthesized by the Cal gene on chromosome 11 during sepsis and inflammation. Now produced by again by the hepatocytes after being induced by IL-6, not affected by mode of delivery, and starts within 2 hours after stimulation. It peaks by 12 to 24 hours and has a half-life of 24 hours. So down-regulated by interferon gamma, which is commonly produced in response to viral infection. So I can say the procalcitonin comes faster than or first than in comparison with CRP. So CRP by the time the second day, but Procal can be positive or can be high value from 2 hours onwards. And this is also produced by the IL-6 induction in the hepatocyte and CRP. But I will tell you, for diagnosis of CRP, I mean sepsis, the negative CRP or negative procal is a marker that we should rule out, or we can have a dictum that we have ruled out sepsis. So possibility other sepsis mimicker has to be kept in mind. The procal level, there are many studies are there. So they first day of life, the procal is not much affected. Second day and third day it comes down. So it is less affected by the stress component. So that's why if you compare both procal and CRP, that only onset sepsis, late onset sepsis, always it comes faster than your CRP value. CRP more specific, but more influenced by many other factors like surgery, trauma, or mode of delivery. More for ruling out disease, monitoring treatment. Procal more sensitive and levels as per normogram. So more sensitive is procal. So procal positivity goes towards sepsis, and CRP negative rules out the sepsis. The very pointer we must remember in our sepsis management. Other markers, indirect markers, complete blood picture, TLC, that is total leukocyte count, IT ratio, immature to total neutrophil, I mean ratio, absolute neutrophil count and platelet count. Largest cohort, they say the WBC, IT ratio, and ANC platelet counts are measured on day 3 of sepsis. Results were compared with culture negative newborns. 60% of culture positive newborns have normal TLC. So TLC is not a good marker. 82% of culture positive newborns have normal platelet. 69% of culture positive newborn has normal IT ratio. If all four parameters are normal, only 0.6% have positive sepsis. So that means increase leukocyte count, IT ratio increase more than 20%, and absolute neutrophil count if it goes high, then the probability. But always we remember the CRP positivity is seen in many other conditions like stress, but we have to stress upon the positive procal if the facility is available at the hospital setup. So neutrophil counts, that we see these neutrophil counts go high in cases of newborn, but particularly we have to know how we are interpreting. Sometimes because of the stress, the neutrophil count also can go up. Blood culture is the gold standard of diagnosing neonatal sepsis. Sensitivity around 15% in our cohort in late onset sepsis. Bacteric method nowadays is available. It gives a better yield for the organism, and it can be obtained from 24 to 48 hours. And neutralizes common antibiotic except imipenem and meropenem. So that is the drawback and limitation of Bactec. Contaminant in mixed flora, delayed coagulase negative staph aureus growth is more than 48 hours. Strict asepsis is important because bacteria is very sensitive. 1 to 3 ml of blood is required, not to use arterial lines or PIC line or UVC lines in cases of I can say this Bactec method. Urine analysis many a times very useful in newborn, particularly male newborn, and we must know the male newborn, the obstructive uropathy is very common, PUB is very common. So that's why any child who comes with a no stream of the urine and there is bladder is palpable, we have to suspect obstructive uropathy. In male it is PUB. So performed if known UTI anomaly, urinary anomalies or KUB anomalies, heart catheterization or visible turbid urine. So urine routine more than 10 WBC per ml in uncentrifuged sample. Urine culture from fresh catheter suprapubic aspiration in cases of newborn, and it has been seen that more than 50,000 colony forming unit in any sample of suprapubic or clean catch midstream urine, which is very difficult to collect, but more than 10,000 CFU in positive urine analysis and signs and symptom of this sepsis, it is valid that we can say it could be a case of urosepsis. Interpretation of CSF, that whatever we say in big children, this is CSF is abnormal, that may be normal in cases of newborn. So if you come back to newborn, particularly low threshold for gram negative late onset sepsis, no use in measuring blood glucose. So that means preterm babies WBC can go up to 25, protein can go up to 170, WBC more than 100, or glucose less than 25 has among the neonates with blood culture prevent sepsis. WBC is more than 10, glucose more than less than 25, and protein can go up to 170 plus. Sometimes in preterms that the count can go up to 30. and out of them 70% can be of neutrophil. So fungal infection, those who are having long-term stay in NICU or long-term stay in SNCU, we can think of fungal sepsis because four or more vital organs are typically involved. Prior to documentation of candidemia, a positive blood culture for candida should almost never be considered contaminant. Only 37% of infants with proven candidal meningitis had a positive blood culture for candida. Normal CSA parameters are important, present in almost half of the infants with candidal meningitis. So we have to see the 1,3 beta D glucan is a fungal cell wall component. The sensitivity is only 50 to 60%. High index of suspicion where a improved child or newborn is going deterioration, then fungal etiology has to be thought of. So again, treatment resistant to antibiotics, that is carbapenem resistant or third generation cephalosporin aminoglycoside, fluoroquinolones, though it is not used in all the centers across India, but it can be used, and colistin has to be reserved for many bugs, particularly Acinetobacter and Enterobacter, those kind of organisms, they usually sensitive to colistin. So Enterococcus staph aureus, all those organisms resistant to any of the carbamide was observed in Acinetobacter, Klebsiella, and E. coli because they usually these gram-negative pathogens most likely sometimes they go for a resistance transfer, and because of that plasmid transfer, they are resistant to common antibiotic used for them. Methicillin resistant was documented in 72% cases. So MRSA, so we have to think of vancomycin. Close to 95% of GPC gram-positive cocci were sensitive to vancomycin. So vancomycin is a good drug once it is gram-positive sepsis we are dealing with. So when to start antibiotic in early onset sepsis, so that means risk factors are there. Diagnostic test is suggestive antibiotic has to be treated empirically. So once blood culture positive continue and lumbar puncture, yes, plus minus management, then definitely that blood culture negative infant remains well. So continue antibiotic. If mother received antibiotic during blood culture negative infant remains well, data are normal, then discontinue antibiotics. So that means that is probable sepsis. So in other words, risk factors are there, chorioamnitis and blood culture at birth is giving rise to and antibiotic. They are blood culture positive. Definitely we have to blood culture negative infant remains well, then continue antibiotics. If mother received antibiotics, blood culture negative, data normal, then we have to stop antibiotic. So in this way, risk factors, everything, only blood culture positive has a very good marker of continuation of early onset neonatal sepsis. Treatment choice of antibiotics for units with access to antibiotic data about third generation cephalosporin unless and until meningitis is proved out. Combine antibiotics for the synergism, first line 60 to 70%, second line, but always data for last 6 months prevalent organism and sensitivity. They always say that choose first and second line both. So that means ampi amica or ampi genta and sometimes cepho amica or cepho genta is the choice. So where few strains are likely resistant to common antibiotic, sepsis and pneumonia. I have already told ampicillin plus genta or amikacin. Meningitis, ampicillin plus cefotaxime will be a combination good because they are synergistic to each other, and sometimes listeria can cause meningitis, and that's the reason ampicillin being the drug of choice. We are adding ampicillin to cefotaxime in cases of meningitis. But where the drug that means dosing will be on a higher side, cefotaxime more than 100, that is 100 to 300 milligram per kg in divided doses. Where most strains are likely to be resistant, Cipro or piperacillin tazobactam is the second line plus amikacin. Second line meropenem, add vancomycin if MRSA is suspected. If MRSA organism like MRSA staph aureus is suspected, then vanco will be the drug of choice. If reports show resistant to empirical antibiotic, then neonate not showing satisfactory clinical improvement, then we have to change the antibiotic. 48 hours later, if the baby is not improving, then we have to consider whether to scale up the antibiotic in an escalated manner or not. And if the baby is doing well, if the culture is negative, if the data or all everything is on a normal, so definitely we have to think whether we are doing with a protocol for culture negative sepsis or a prevent sepsis, then we have to de-escalate the antibiotic. Even empirically it has been given escalated one. So duration of antibiotic depends on the organism. So negative biomarkers, culture and clinical course not suggestive. Stop the antibiotic overnight. Culture negative probable sepsis or pneumonia 5 to 7 days. Culture positive sepsis but meningitis is not there, then 2 weeks. Meningitis none other than 3 weeks. Ampicillin plus cefotaxime. Ventriculitis, again, it is much more than 4 weeks to 4 to 6. Bone and deep-seated infection, septic arthritis, 4 to 6 weeks. Deep-seated abscess, 4 to 6 weeks. So there is infectious disease guideline says for neonatal candidiasis, amphotericin B, sometimes fluconazole loading and lipid formulation amphotericin B, and echinocandins, other fungostatin is also can be used, and removal of the central line. Duration of therapy for candidemia 2 weeks after documented clearance of candida by blood culture. So there are guidelines for neonatal CNS candidiasis in that amphotericin B 1 mg per kg IV. Alternative regimen is liposomal amphotericin B in addition to flucytosine. That is another drug for step down treatment. We can use fluconazole 12 milligram per kg daily in recommended for isolates that are susceptible to fluconazole. In cases infected central nervous system devices, including ventriculostomy, we can go for that and definitely should be removed if at all possible. So take home message, dear doctors, that pediatric sepsis we get more commonly or very nicely in age group of neonates. So neonates are more vulnerable for sepsis, and early diagnosis is not only clinical, but it is to be lab parameter, the CRP and procal, and CRP is available. CRP negative is more predictive value than procal sensitive. I mean high sensitive is procal positivity. Most common cause neonatal death after 6 days of life is neonatal sepsis. Symptoms are non-specific. Organism profile same in early and late, but however, gram-negative organisms they are more common. Procalcitonin a little better than CRP, provided it is if it is available, then it has to be used because it is costly and CRP is available everywhere. So CRP is the one of the commonest tool used for the diagnosis of sepsis in children. Serial CRP move value than a single value is more important. Ruling out meningitis in all cases of late onset sepsis or neonatal sepsis is very important. De-escalation to the narrowest possible spectrum of antibiotic is very important in cases where the baby is doing well. If the baby is not doing well, despite our clinical spectrum and data, whatever is available, then definitely up or escalation of antibiotic is very important. So thank you very much. And now it is over to Upsin. If there are any questions are there, definitely I will love to answer. It is
Thank you.
over to Upsin.
Thank you so much, sir, for this wonderful session, sir. With all your permission, sir, shall I take question? Okay. So the first question is, what are the earliest clinical warning signs of sepsis in neonates and young children that should be never be overlooked?
Okay, so earlier signs are there. Anything what is happening from the normal day-to-day life, particularly in neonates, that says that the baby is having something wrong. For an example, the mother will tell, so from since morning my baby is not sucking the way the baby is used to suck before. So that means difficulty in feeding, baby is a refusal to feeding. This is one of the earliest in the feeding pattern alteration. Number two, vomiting. If the baby used to vomit or push it out, that is normal. That we are managing with burping. But if the vomiting continues, then we can think that there is something wrong. Then comes your distension of abdomen. Then comes the baby's whole body became became always it is warm. Now it is going towards cold extremities and cold trunk. So that means hypothermia. Sometimes hyperthermia, high temperature in a newborn. And if you see, there are some signs like mottling, and the baby is not active as before. If the baby is lethargy, just like not active, not crying well, then definitely we have to think these are the signs. And for sometimes you can palpate the fontanelle, which is bulge and it is tense, then it is there. Then you see the icterus, jaundice, neonatal jaundice. Physiological jaundice is okay, but touching the palm and sole is not normal. Then comes your cyanosis, if the baby turns blue, or sometimes the baby is tachypneic, respiratory distress, too much amount of cough, and the baby is not breathing well, apnea or tachypnea. All those things, anything which is abdominal distension, blood in the stool, I mean, again, vomiting, and vomiting contains bilious vomiting. Any baby bilious vomiting has to be thought of either mechanical obstruction or neonatal sepsis. So I think the normal baby is normal as long as the baby maintains the temperature, sucks from the breast well, and play in between when the baby is awake. So this is the normal journey of a newborn. in a day-to-day life. But any deviation from normal can be a marker of clinical sign and symptom of sepsis. So these are known as danger sign in a newborn. So I have already told any deviation from the normal, particularly in a neonatal period, has to be thought that it am I not dealing with sepsis. So that has to be kept in mind. So that is the reason if we suspect sepsis, then definitely we have to follow the kid. And if the baby is continuing or by evening the baby is well, so then almost we are not dealing with. Whenever there is the deterioration, symptoms are much more hours after hour or day after day. So definitely we have to admit the child. We have to prove whether sepsis is there or not by doing blood investigation, by doing CSF investigation, and proving and treating with IV antibiotic. There is no role of oral antibiotic in the treatment of neonatal sepsis.
Okay. Okay, sir. Thank you so much, sir, for this brief answer, sir. I hope you did justice with the question. So the next question is, how can pediatrician differentiate between severe infection and early sepsis in routine outpatients or emergency settings?
Okay, so this is early sepsis and I mean severe sepsis. Severe sepsis, and it is a pediatrician, that too for a big child. I have already told about the neonates. Now coming to a big child, if the child is big, let us tell 5 to 6 year child. So in that condition, what is going to happen? Usually, the baby is okay and all the child is okay, but suddenly the child became lethargy for last 2 days. Any convulsion, the child became unconscious. Then definitely all the child is having blood vomiting or abdominal distension. We can think of sepsis is there. That means we can think severe. But how to know the early sepsis? Early sepsis is very difficult to guess in a child because they are playful. Unless and until they are having some moderate to severe affection, then only they will be doomed and they will be inactive. Otherwise, children, they are by age, they are very active. They used to do and roam around the body, I mean, in the home, and they play. But once the child is not playing, suppose vomiting, or the child is having high grade fever, or the child is having abdominal distension, the child is not feeling well, something, the child is having headache, and there are 2 bouts of vomiting. If there is anything which is pointing out that, for an example, I will tell that if there is headache, if there is vomiting, if there is fever, if there is burning maturation, if there is suppose blood in the stool, all those things, if it is happening less than 1 day also, we have to think, are we not dealing with any infection? I cannot say this is sepsis as a terminology to be used in a big child. I'll tell local infection. Because neonatal sepsis, the sepsis is not limited to one part of the body, it is generalized sepsis. So we used to use the term neonatal sepsis. But in big children, we used to tell local infection like otitis media, like UTI, like abdominal sepsis, like meningitis. But we rarely tell sepsis, particularly in cases where sickle cell anemia or immunocompromised host, we can tell sepsis. So my answer is that any child who presented with severe sepsis or moderate sepsis, anyone can diagnose. But thinking about I mean early sepsis is very, very difficult. In those conditions, you have to see the child again after 24 to 48 hours. If the child worsens or if the child deteriorates, so definitely you have to think that you are dealing with a sepsis, and you have to admit, or you have to give antibiotic judiciously. For an example, I will tell the child is having high grade fever and sore throat. Now, you cannot say this is sepsis because sepsis means it is bacterial. Now, if you look to the throat by a touch, by a tongue depression, you see it is an angry looking toxin, very red, and the child vomits out, high grade fever. But that is not sepsis, it is a viral. So that viral, you give paracetamol, you give a soothing agent just like honey, and you give allow the child some running nose or cough is there, antihistaminic at night. After 2 to 3 days, the child will be normal. So this is not sepsis. So all that sore throat with high grade fever doesn't mean they are bacterial. 75% cases are viral. So viral with bacterial, number one point, there are viral prodromes are there, like running nose, cough, sore throat, and the interfebrile period, the child is playful, that is viral. So no need of antibiotic. But if the child, despite of paracetamol interfebrile period, the child is not well, and the child looks toxic, the child looks sick, and the child is frustrated. Even if mild temperature, the child is not feeling well, only sleepy. Then that child has to be kept. That this child is a septic child. Let us see, let us investigate, and let us treat as early as possible. Yes, over to Apsi.
Thank you so much for this brief answer, sir. So the next question is, how does timely initiation of antibiotics and fluid resuscitation impact outcomes in pediatric sepsis?
Can you repeat again, Afsin?
Okay, sure, sir. How does timely initiation of antibiotics and fluid resuscitation impact outcomes in pediatric sepsis?
Yes, pediatric sepsis timely initiation of antibiotic is always thought proven. For an example, I'll tell you if I am dealing with the early onset or a late onset, the organisms nowadays the book says and everybody says it is almost similar. So the duo antibiotic, that is not an empirical antibiotic. For all diseases, we should not wait till the report will come. Now, before the report, we are admitting, sending the body fluids for the data, for the investigation, we are starting the antibiotic. And we can modify to escalate or de-escalate or can stop. There are three modes. So if I have started antibiotic in a child and I have admitted the child, but I prove that this is not a sepsis, I can stop them at that. If the data says there is a mild infection, I can give for a short duration of antibiotic. If I see that after 14 hours the child is not, I mean, child is not doing well. So that means I can escalate the antibiotics after 40 hours. So in that scenario, you have to know that this business depends on three factors. One is clinical improvement. Number two, the lab data. Number three, the organism which is coming in the blood culture or tissue culture or body fluid. So that has to be kept in mind. Then only we can say what we are dealing with. Yes, yes, Absent.
Okay. Thank you so much, sir.
Yeah.
Sir, I am audible to you, sir?
Yes, audible.
Okay. Sir, with all your permission, shall I conclude this session, sir?
Uh, yes, yes.
Okay. Okay. Thank you so much, Professor Dr. Kumar Agarwala, sir, for such enlightening and clinical impactful session, sir. Your emphasis on early recognition and prompt action in pediatric sepsis has provided invaluable guidance to all of us. On behalf of IJCP, I extend a heartfelt thanks to all the doctors and participants who joined us today. Wishing you everyone a safe, healthy, and pleasant evening ahead. Thank you and take care.